Thanks very much, Beth and Graham, for inviting me to talk today. And hello, everyone. I hope you'll find this meeting interesting. And I totally agree with your comments, Beth, before what you showed about so many aspects of the immune system that can be responsible or could be affecting somebody developing aspergillosis. And also, Graham mentioned the whole spectrum of the disease, including allergic, chronic aspergillosis, and also invasive disease. So we like to see it as a spectrum of disease. What I'm going to talk about is what we have been doing here at the National Aspergillosis Center to try to understand why do some patients with chronic pulmonary aspergillosis develop the disease. It's a matter of research, and I'm sure Margarita also covered some part of it in terms of the function of the epithelium of the lungs. But over the years, what we have seen also is that there are some subtle defects of the immune system in patients who develop chronic pulmonary aspergillosis that could potentially predispose these individuals to develop the disease. So I'll show that the data that we have been working with and the findings that we have over the last few years. And then in the end, I will mention about the clinical trial that we are having. I think you're seeing now the wrong display settings. You're seeing, maybe that's better. Okay. So as I said, here at the NAC, we following patients mostly with chronic, but also with allergic aspergillosis, and Hugh already covered that aspect earlier on. And what I like to start with is share this concept of the spectrum of disease of aspergillosis. So what Hugh was covering earlier on is what we see on the left-hand side of this graph. So patients who have allergy to mold, which then develops into a quite extensive inflammatory response in the lungs with all the consequent conditions like bronchiectasis and then reduction in lung function. So that's why you have to treat allergic aspergillosis quite aggressively. And on the opposite side, as you see on the right-hand side, are those patients who have a very weak immune system. These are patients with, for example, with blood cancers, or patients who have high doses of steroids over a prolonged period of time, or other immunosuppression. And these patients their immune system is known to be very weak because of those interventions or because of disease. And these patients are very susceptible to invasive aspergillosis. So this form of aspergillosis can be quite rapidly progressing, and if not recognized early, could lead to death. And that's why some of these patients actually take antifungal medications as preventative agents when they have chemotherapy, for example. So these are the two extremes of the immune response as far as what aspergillus can cause. And in the center of that spectrum is what I would like to talk about. It's the chronic forms of aspergillosis. So these are not really allergic diseases, and they're not really invasive diseases. So this is disease that happens in patients who always have some form of prior lung condition. I will show you an example of some of these conditions, or at least what we see at the Aspergillosis Center. So these are conditions where somebody has had some form of lung condition, usually resulting in what we call a lung cavity, which is basically some part of the lung that does not have the usual lung tissue, but there is an area filled with air because of previous condition. But in addition to that, there is also so there is growth of mold in that area, but also surrounding that area there is some inflammation going on, which is then resulting in symptoms for these patients, like usually a cough with blood in the phlegm, or weight loss, or feeling unwell and feeling tired, and so on. These could be symptoms of chronic aspergillosis. So then, why would a patient develop chronic aspergillosis? Because these are not really patients who have chemotherapy, or patients who have usually blood conditions that result in very low white cell counts. So, but we do understand about aspergillus that it is what we call an opportunistic mold. So it is usually a mold that does not cause disease when the immune system is intact, and we all breathe in Aspergillus spores every day, and they're usually cleared by the immune system. I'm sure Margarita covered also about how the epithelium of the lung, as maybe one of the first lines of defense, can remove the Aspergillus spores before they cause any damage. So we all inhale Aspergillus every day, but only a few people will get disease. So why does this happen? Why does the immune system then is not able to eliminate that? So usually what would happen is that when the spores that we have inhaled try to proliferate in the lungs, the cells of the immune system will rapidly go there and swallow them and then kill them. And this could be the macrophages, what we call them, could be the epithelium, could be then lymphocytes will come as well. And neutrophils is a major type of cells. So then CPA patients are really not typically immunosuppressed in that way. So there could be some subtle problem which we don't really understand very well. So why would a patient develop a chronic aspergillosis condition? So if we can find the immune defect in these patients, maybe we can help with treating this specific defect if we can. That's another way to show how we understand the pathogenesis of aspergillosis. How does aspergillosis happen in somebody whose immune system is very weak? As you see, we inhale the spores of Aspergillus. That's how it looks like under the microscope, as you see on the left. So then these little spores will end up in the lung, and then they will try to gradually invade. So then they will invade if there are no immune defenses available or functioning, and then this will happen. This will lead to invasive aspergillosis. But in chronic aspergillosis, is a kind of different picture. Here on the left column is the conditions that we see at the Aspergillosis Center as the most common conditions that patients present with, who eventually then develop chronic aspergillosis. So as you see, the most common one probably in our setting is COPD, also known as emphysema. This is what is also called as obstructive lung disease, often related to smoking. And this is probably the highest or the most common underlying condition in patients who develop chronic aspergillosis, because COPD leads sometimes to what we call bulle in the lung, or some areas of the lung where there is no adequate air exchange, and then there could be some areas where aspergillus can actually grow in there. What is also very common is to see CPA developing after treatment for tuberculosis, a very common infection globally, and probably around the world. Tuberculosis is the most common condition leading to CPA. And as you see on the right hand side, this is a compilation of the numbers from other studies around the world. So globally, probably tuberculosis is the most common cause of CPA. Here in Manchester, probably COPD is the most common. But you see a range of other conditions that we see in patients who have who we see here in Manchester with CPA, who have had this previous condition. So it could be things like pneumothorax, which is some injury to the lung leading to air accumulating surrounding the lung, and that sometimes needs surgery. People who have had lung cancer and they have been actually treated with it and by surgery, and the cancer has been removed because of the situation with the surgery, and then maybe they have COPD as well, they can develop CPA. Also, people who have had serious pneumonia sometimes can end up with CPA in the end. And all of these conditions, what they have in common is that they have some form of lung or tissue damage to the lung, which then results in what the Aspergillus then uses to establish the infection going on in the lung. So what happens in those areas, what we call cavities sometimes, because they're filled with air, sometimes Aspergillus, because we inhale the mold and then it can end up in that cavity, then it can grow into what we call, sometimes we call it an aspergilloma, or also we call it fungus ball. And patients with CPA might have this developing there. Now, sometimes this can develop and does not cause any symptoms. Sometimes it is possible that it just walled off and not causing problems, which is also possible. In those cases, you may not have to treat a patient. But sometimes it can also create inflammation surrounding the that cavity. So these are all sorts of images. Essentially, we can see on an X-ray or a CT scan and every patient with CPA will have a CT scan of the chest when we first see them, and also after they have received treatment, usually about 6 months after. So what we have seen from our experience, now I'm going to just present to you our thinking over the last few years and our research on the topic. So what we have established over several years of working with our immunology colleagues here in Manchester and also in Cambridge, with whom we have been collaborating to try to understand the immune function in patients with CPA. So what we have seen over the years is that patients with CPA may have reduced production of one of the proteins produced by some of the immune system cells, mostly lymphocytes, something called interferon gamma. So this is a protein, it's called a cytokine, essentially. It's a signal molecule produced by some of the cells in the body or in the tissues when they encounter some of the bacterial or fungal components when they invade the body, and then this promotes the immune system, especially in the form of boosting some of the cells that can go there and kill the fungus or bacteria sometimes. So what we try to see is to try to see if in CPA patients there is a defect in the production of this cytokine called the interferon gamma. So what we have done is that we have collected samples from patients with CPA, but also we needed to have as controls some healthy controls, so we don't have CPA. And then looking at the ability of the cells in the blood in CPA patients to see if they can produce enough of this interferon gamma. And to do that, you stimulate those cells with various microbial antigens. As you see here, all these are antigens produced either by bacteria or by fungal organisms. So this zymosan or beta glucan, those are antigens produced by Aspergillus, but also other fungi as well. So what we saw is that when we stimulate the cells from CPA patients, they produce less interferon gamma compared to healthy controls. So that could be one of the reasons why the immune system is not capable or adequately fight Aspergillus, but also it's possible that could be other infections that this interferon gamma can fight against. We know it is important also in the immune system's defense against tuberculosis. This is also well known. So as you can see on the bottom left, you see this graph. It's called the box plot of the how much different is the production of interferon gamma, and in the light blue color you see healthy controls, and then with the purple or the orange color is the CPA patients. As you see, in most of the comparisons, the CPA patients had reduced production of interferon gamma, and so this could be some form of immune defect in patients with CPA. Of course, we haven't compared with other disease groups, but we compared with healthy controls. But it definitely shows that there is some difference there. So then interferon gamma is available in the NHS, so it is prescribed for some medications, and we have given it to our patients with CPA again over the years, and we have tried that in patients who fail treatment with antifungal medications. So in CPA, the main treatment is antifungal medications given for several months in the form of tablets. These are called azoles like itraconazole or voriconazole, or there are others as well. But unfortunately, it happens sometimes in CPA that patients can develop resistance to these agents, but can also develop side effects. So then you have to try other medications like intravenous drugs, which is obviously not very good to give very long term. So then for these patients, we have tried and we have given interferon gamma over the years when they have failed the antifungal treatment. Now, interferon gamma, there are some challenges with this medication because it has to be given as an injection. It doesn't exist in tablet form, so there is that. And also, it can cause side effects. In fact, it can cause fever, or it can cause a patient to feel like they have the flu. They can get achy bones and things like that. Of course, these are not dangerous side effects. These usually go away after a day or two after the medication is not given. So they are reversible and not long-term problems. But some people really cannot tolerate it, so this is understandable because of the side effect profile. However, we had a number of patients. This is a study that we published a few years ago, showing that we saw what happened in a number of patients who received this treatment, and it was tried in 36 patients, and about 20 of them were able to continue it for at least 12 months. As I said before, some patients have to stop it because of side effects, so it's not a perfect treatment that not everybody can tolerate it, but there were patients who tolerated the treatment. And you can see there what we are depicting here, and on the graph on the left is what we saw actually surprisingly was that patients who received the interferon gamma for a year had a reduced number of exacerbations. So that means flares of their chest disease. So patients who have, for example, COPD or bronchiectasis or asthma, they might get what we call flares of disease, which means they have to see their doctor usually for antibiotics or steroids. And sometimes they can even get admitted to hospital. It's really important to control these exacerbations. They are known to result also in sometimes poor outcomes in patients because there's also the deterioration that they feel, but they can also end up in hospital. So that we have seen. And you see on the left-hand side, these are those events in those 20 patients the year before they went on the interferon gamma treatment, and you see the exacerbation number is quite high. It's very variable, of course. Some patients are very frequent exacerbators, and they have to see their doctor very often. And also the number of hospital admissions was quite high. And then you see in those 20 patients who were able to complete 12 months of interferon gamma, in the year when they were on interferon gamma, you see the number of exacerbations was much less. And the number of hospital admissions was much less. So you see the exacerbation rate was before treatment was about 3 per year, and then about 1.5 per year the year after. And hospital admissions also from 0.8 to 0.3. So there was a reduction in both of these parameters, quite significant outcome in our opinion, because this is something that a patient being in the hospital sometimes can have complications. So of course, not everyone benefited, as you can see. So some patients didn't really see a huge benefit, but we feel the majority of patients actually from that study, what showed is that these patients actually were able to maybe stay out of the hospital for longer. So we really felt that there was a potential benefit for some patients, at least, when they are given this treatment. So obviously, this medication is not, we don't know enough about it in terms of if we give it to more CPA patients, is it something that would help, or would it help only those patients who do not have any other options, as was the case here? So what we went on and did is we applied for a grant through NIHR to try to do a feasibility study, meaning we want to see if it is possible to do a larger study when we can try interferon gamma in chronic pulmonary aspergillosis from the beginning. So this means when you are starting antifungal treatment, can we actually give interferon gamma together with the antifungal and see if this can make a difference? So what we're aiming to do is that we want to recruit 50 participants over 2 years. So for participants to be eligible, they have to have CPA, of course, and they have to have started an antifungal medication within the previous 8 weeks. So they have to be a recent onset of treatment, and they should not have had any antifungals for the few months before this antifungal was started. This is only so that we can have a better assessment of the effect of the antifungals. Participants who have another active infection like TB they will not be eligible because we really want to see the effect of interferon gamma on CPA specifically, not on other infections. And this is a randomized trial, meaning that participants who consent for the study, then they will be randomly assigned to either be given the interferon gamma for 3 months, and this is given, as I said, 3 times a week, or just continue the antifungal medication. And in any case, the antifungal medication, we don't interfere with that. That continues as part of the routine clinical care. So half of the participants are randomized to receive additional interferon gamma. And what we are measuring in the end, obviously, is how many participants have been able to complete the course. And in terms of assessing the benefit, there are some questionnaires that we use, some quality of life scores. And there is one called the St. George's questionnaire and some others that we're using. And I know there is a session later on about a novel quality of life score that is being developed, and that will be presented in the afternoon, I think. But we're also looking at the CT scans of these patients in terms of we will ask our radiologist to comment on whether the CT scan looks better. So that's usually measured in the thickness of the cavity wall, which reflects the inflammation in the wall. So it's not only the symptoms, but also the appearance on the CT scan that we would like to look at. So what's the aim of this study? Obviously, 50 participants is not a huge number to make clinical conclusions, but obviously it will tell us whether this study is feasible in a larger study where we'll have to do it in many different clinical centers. At the moment, we're only conducting this study here in the National Aspergillosis Center in Manchester, and we have started recruiting patients since May of last year. So we're relatively early on in the study, but we have recruited a number of patients, and we're continuing this will continue for 2 years. And that's the more information about the study. So obviously, participants who would like who are interested in that, obviously we need they would need the advice of their own clinician. The clinician would be able to advise them whether they would be eligible, and obviously, most importantly, whether they would benefit from participating in the study, whether it is okay for them to participate. So we always like to discuss with external clinicians who might have patients who would be appropriate. Of course, if a patient is already under our care at the Aspergillosis Center, we would assess that ourselves. And this is the information you can find about the trial.